Okay, greetings everyone. My name is Amit Jain, Associate Professor of Orthopedic Surgery at Johns Hopkins and a practicing spine surgeon, and I'm joined by my co-host, Mario Massis, who's a Professor of Economics at the Carey Business School. Welcome to our webinar on physician non-competes. We're really excited for you to join us today.
Thank you, Amit. Thanks everyone for joining us. So quick introduction to today's topic. We are here to discuss and understand non-compete agreements as they apply to physicians and healthcare professionals and their far-reaching implications. So these agreements are commonly employed by health systems in the context of our discussion. They're obviously employed more broadly, but they're employed by health systems to maintain a competitive advantage in exchange for making investments in a physician's practice. So non-competes typically restrict employees from joining competitors or starting similar businesses within a specific time frame, usually and often with a certain geographical area after leaving their job. However, these agreements are increasingly scrutinized for their potential to restrict workers' job mobility, suppress wages, inhibit innovation. So in today's conversation, our goal is to better understand the role of non-competes in the healthcare sector, how they might impact patient access to healthcare, their differential impact on different types of physician practices, and other aspects. Amit, up to you.
Okay, today we are very lucky to have an amazing panel of national experts who will explore the different dimensions of this very divisive topic. So before we introduce the panel, just wanted to give a big shout out to the Hopkins Business of Health Initiative, which is a tremendous group of academics, public health experts, economists, and physicians working together to tackle big problems in healthcare. Really want to thank Dr. Dan Polsky for leading our group. So our first panelist is Attorney Danielle Drury, who is an attorney advisor in the Antitrust Division in the U.S. Department of Justice. She'll be providing the regulatory perspective. Our second panelist is Ms. Stephanie Quinn, who is a Senior VP of External Affairs at the American Academy of Family Physicians, and will be providing a physician perspective. And our final panelist is Professor Barak Richman, who is a law professor at GW and leading the new Law and Medicine Center there. So it's a really outstanding group, and we are excited to have them and thanks them. So for the audience, we encourage you to use the Q&A feature to ask any questions, and hopefully we can pepper those questions through our panelists. So let's get going. So first, Danielle, can you give us an overview and talk about the benefits and problems with non-competes, and tell us a little bit about the FTC and DOJ position?
Great. Yes, thank you so much, Ami and Mario, for having me today. I was so excited to hear that you all are thinking of these issues, and look forward to the discussion with all of the panelists here. Before we get started, I do have to make the standard disclaimer that my views are my own and do not necessarily reflect those of the Department of Justice. I think Mario gave a great overview just now of the background of non-competes. These clauses are often found in the employment agreement executed when a worker is hired, but we're increasingly seeing these contained in standalone contracts that can be executed at any point in the worker's employment. As Mario mentioned, they generally prohibit the employee from working for the employer's competitors after leaving their position, or from even starting a business that competes with the employer. So in the physician space, you can strike out on your own as a physician, maybe open your own practice. A lot of the non-competes we're seeing do actually impact the physician's ability to do that. So happy to discuss that in greater detail, but just wanted to add that as a nuance here. Non-competes have really generated a lot of news recently for their pervasiveness within the American economy. They've been used in various industries, including healthcare workers, like many in this audience, highly paid CEOs, warehouse workers, and even fast food employees. I think one of the most commonly cited examples for a non-compete that perhaps didn't need to happen was Jimmy John's sandwich artists were subject to non-competes. So they're really used in lots of different industries, and I'm happy to talk more about the physician context today. The good news is that the discussion around non-competes is changing, and there are a lot of efforts to minimize or ban them altogether. Some states, most recently Colorado and Minnesota, have made non-competes completely unenforceable. And as we alluded to at the beginning of this discussion, the FTC has also proposed a rule earlier this year that would significantly limit the use of non-competes economy-wide. So you had asked about the harm that non-competes can cause. And I think really they have the greatest impact on worker mobility. Just imagine when you are applying for jobs, you probably weighed those attributes before accepting the job that you ultimately choose. And employers similarly look at candidate attributes before offering them jobs. This is often known as the matching process, which I understand for physicians, matching takes on almost this exact meaning, but maybe in a more formal sense, given your match days. But when labor markets are competitive, this process leads to better worker outcomes, higher pay, better job quality, like things like benefits, the hours worked, and this also leads to more productivity for employers. But non-competes can disrupt this competitive process. They make it difficult for a worker to change jobs to find a better match. Let's say you're super unhappy in your job, you're not productive, you're not getting paid what you should be getting paid. When you have a non-compete in effect, you cannot switch jobs. And this also impacts employers, which may find that the best candidate for their job is prevented from accepting their job without serious ramifications because they're tied up in a non-compete clause from a different employer. When we look at this, the effects economy-wide, this affects both workers and employers in the form of lower wages, lower job quality, and less worker productivity. There have been, maybe I can just briefly go through some of the research that has been done in this area. So there is a wealth of empirical research that is starting to come up to the surface with respect to how many people are subject to non-competes. This is really hard to measure economy-wide. Our most recent estimates are something like 20% of workers are subject to non-competes, but there has actually been a study focusing solely on physicians, and they found that 45% of physicians are subject to non-competes. So you can see that this might be an area that may impact the healthcare industry greatly. And studies also find that non-competes lead to a reduction in wages, and these studies predict that banning them would lead to an increase in wages economy-wide. The numbers on this vary from study to study, but estimates put the effect at anywhere from roughly 3 to 15%. Just to put that into perspective, stepping back, that would put hundreds of billions of dollars in the pockets of American workers if we just did away with non-competes. So given all these harms, why do employers even choose to impose non-competes at all? Again, Mario alluded to some of the most commonly cited reasons. Most of them want to say that they help increase employers' incentives to make productive investments, including in worker training and sharing trade secrets. By also requiring employees to stay in their jobs longer, they can recoup some of the costs of training. You know, if you're a physician and you go through specific training for a couple of years, well, employers can generally recoup the cost if you stay on 10 years versus leaving the next year. And then the last one is that they often reduce trade. They say that they reduce trade secret misappropriation or the loss of confidential information. I will say there's little empirical support for these justifications. And in the case of things like trade secrets and disclosure of non-confidential information, there's other ways to get at this, like the use of NDAs or prohibiting through different types of contracts. So that's just kind of an overview of the potential benefits and harms of non-compete clauses. And I'm happy to talk more about FTC and what DOJ is doing, but wanted to turn it back over to you guys to discuss some of the more interesting areas with respect to health workers.
That was great. Thank you very much, Danielle. So our next question is for Barak. So Barak, considering that non-competes have existed for a long time, like with variation about their enforceability across states and so on, but they have been around a long time, including in the healthcare sector. So are there changes in the healthcare landscape that suggest that we now need to think about them differently? We need to reevaluate their role, their impact. We'd love to get your perspective on that.
Yeah, of course. And let me also just start off by saying that it's a pleasure to be here, pleasure to be part of the Business of Health initiative at Johns Hopkins. And also the views that I express here are not those that can be attributed to George Washington University, or if any of its entities use non-compete clauses, not to those departments as well. So I think there are two things that have happened. And I think all of this has happened within the backdrop of declining wages as it relates to economic growth. One is that non-compete clauses have been used far more widely in the last decade in industries where there was never anticipated that there would be any kind of pro-competitive benefit. The Jimmy John's example is one of them. But your question specifically, and it's a really important one, addressed specifically the health sector. And have there been changes in the health sector that have that would implicate our understanding of non-compete clauses? And the answer to that for sure is yes. Although antitrust law and law in general has always approached non-compete clauses, non-compete provisions in employment contracts with some ambivalence, and I mean that constructively. There's a sense that it can be useful and it can be unhelpful. In the health sector, especially for physician practices, it by and large has been deemed to be a very helpful, very useful provision to develop physician practices. In the last 20 years, the healthcare sector has changed in a number of ways. Most significantly, that is much more consolidated than it ever has been before. So the economic effect, the anti-competitive effect of non-compete clauses now is much more profound than it was 20 years ago. And part of that is just the way these non-competes tend to be written. They tend to say you cannot find employment within a certain geographic range of any of our affiliate offices. And of course, if the defendant, if the employer gets bigger and has more affiliate offices, then just the actual effect of that non-compete clause is much more pronounced. But secondly, there are simply now in most metropolitan areas and most areas nationwide, there are just fewer employers. The number of employers are smaller. That is that every employer whether it's a physician practice or a hospital that is a party to these non-compete clauses, they dominate more of the market than they did before. And therefore, even the same words in a particular employment contract has magnified effects. The other thing that I think is very important to recognize, especially as it relates to the physician markets, is that we no longer have physician markets that are dominated by independent physician practices. And this is a very recent development. In just the last 10 years, we've gone from a country that has about 3/4 of all physicians part of an independent practice to only 1/4. Most of those physicians are now employed by hospital systems. A lot are employed by insurers and other corporate entities. And of course, you have the pervasiveness of private equity and other firms that are amassing physician groups. This is really significant. I mean, it's significant in all sorts of ways, and including ways that we haven't really thoroughly digested. But as it relates to the employment of physicians, if you have a corporate entity controlling physicians, then you have outsized influence on what the impact of the non-compete clauses are. It's not just the inability to join another physician practice. It's also the inability to create an alternative, an improvement to the current delivery system. If one of our problems is that we have a hospital-based delivery system and all of the costs that such a bricks and mortar model has, then the non-compete clauses don't just stifle competition across physicians, it really stifles innovation in the delivery system altogether. So that's the answer to your question. Why is it different now? It's different now because we have very profound competition problems in healthcare writ large, especially on the provider side. And some of our most foundational problems with our delivery system, its cost, its ossification, are further exacerbated because of non-compete clauses. What to do about it? We'll talk about that a little bit later in the hour.
No, that's really great, Barak. Thank you. So I'm going to kind of build off your comments and pose my next question to Stephanie. So Stephanie, you represent one of the biggest physician organizations in the nation. And do you think it's really fair to apply non-competes equally to big health systems and small physician practices? In other words, do the laws and regulations really, is it fair to take a big system that has a market monopoly or a near market monopoly or at least a oligopoly and then apply those same regulations to a 5-person or a 3-person mom and pop shop of doctors? And what would love your take on that.
Yeah, so thank you for starting this conversation. I mean, I would like to associate myself with everything that's been said so far. We represent 129,600 family physicians and medical students across the country, and I think it tracks with what Barrick was saying. 73% of our members are employed, and 91% of our members 1 to 7 years post residency are employed. So this is happening. I think when it comes to considerations for smaller practices, especially when you're talking about in rural areas, there is an investment of time to kind of onboard people. They're going into communities where trying to attract people to come can be a challenge. And so, it can be very disruptive to have physicians that leave. Having said that, I think when we are looking at these policies, designing it around those very few exceptions that maybe deserve additional considerations, I think would be a huge missed opportunity, because a lot of what we see to be the most egregious behavior is happening by the large health systems, where you're not concerned about backfilling spaces because there are other people there. So I hope we can separate out that we do think that there are times that making sure that physicians who have their own practices, small practices, who are trying not to necessarily, they're trying to compete with some of these larger systems, have the ability to keep and train and attract and retain staff. I think, focusing on these more resourced, larger health systems is probably where the conversation around non-competes belong. I think most of what we're seeing is, it's not just the for-profit systems. A lot of this is in the non-profit systems, and I mean it is pervasive. And I think when you think about the Jimmy Johns, I mean, we see it with members that are practicing in urgent care settings. Like, you're not taking your patients. That's not the function of urgent care. I think our biggest concern is that the suggestion that a health system's interests supersede a patient's need to have continuous care, in our case from primary care, that's a huge concern. I mean, the value of primary care is in the continuity of that relationship. And to put that in jeopardy because this physician is, you may have a difference in your aligned mission. We've all been through leadership or CEO transitions where perhaps it's no longer resonating with your value system. So your choices are to pick up and move and to leave your patients behind. I mean, our members are pursuing primary care because they believe in that relationship. So, it's not kind of this, we want to move here, there, and everywhere. So again, really appreciate the conversation. Happy to dig in further.
Thank you for that. Our original plan was to leave questions from the audience at the end, but the beauty of this conversation is that it's a conversation and members of the audience are part of it. And we received a question from Gary Pushkin, who's a doctor, a physician, and his question has been endorsed by other members of the audience. So I thought that this would be a good, and it's in reference to something that Stephanie just mentioned, the nonprofits. So the question is this, I'm just gonna read it, and it's for all of you. Maybe Danielle, if you want to take it, because you were next on our rotation, but it's really or Stephanie, since you mentioned it. Why is the proposed regulation to do away with non-competes not including nonprofits? These are overwhelmingly employed physicians. So you see why I chose to deviate from the schedule to ask these questions, as Stephanie mentioned. So who wants to address this?
I'm happy to
Danielle,
take
go
the
ahead.
first stab. And so I think when you're talking about the proposed regulation, you're talking about the FTC's proposed rule, which was proposed this January, and it's yet to be finalized. So just want to put out that they're still working on this, and making a final rule takes a lot of time. So I think the comment period is closed, but we should expect to see a final rule sometime soon. I don't have any insight into timing, but turning to your question, it is a great one. So unfortunately, the nonprofits are excluded from regulation by the FTC based on the FTC Act passed by Congress. But I just want to put a plug for the fact, and so that therefore the rule is very explicit that it doesn't reach those individuals because they just don't have the authority to do so. But I just also want to put a plug in for my agency, for the DOJ, where the FTC cannot enforce certain rules against things like nonprofits or other entities that are exempt from the FTC Act. The DOJ can step in, and we have taken certain positions on non-competes in the past. Generally how these are, and I'll just give a very brief answer about how these are scrutinized under the antitrust laws, but generally, and this touches on some of the things that the other panelists have mentioned involving how egregious some of these non-competes can be. When we're looking at these types of non-competes and whether to prosecute them under the antitrust laws, we generally look at whether they're reasonable in scope. So looking at things like, are they, for example, Bobby Brown had to sign a 25-year non-compete when she sold her business to Estee Lauder. That's clearly pretty egregious. Are they geographically not, or are they geographically unreasonable? So if they cover, the entire United States for physicians, you would imagine that that might be something that may be problematic under the antitrust laws. And then the antitrust laws also look to the nexus between the employee's role in access to confidential or sensitive information, particularly when employers are trying to rely on the fact that they've undergone extensive training or have access to a lot of trade secrets. So I would say that even though the regulation may not cover not-for-profit hospitals or not-for-profit entities, which I understand are very pervasive in the healthcare space, that doesn't necessarily mean that non-competes would not be enforced against in the antitrust world.
Could I just add to that one moment? I think that answer, which is a terrific answer, also needs an asterisk, because the jurisdiction. So what the FTC Act does in fact limit the jurisdiction of the FTC on certain conduct, on certain regulatory actions, but that's like the rest of this area, a very amorphous, a very fuzzy area of law. The FTC has managed to go after a lot of different anti-competitive conduct that was coordinated by nonprofits, including nonprofits in the health sector. And the way they get to that is because the nonprofit was orchestrating anti-competitive economic interests for for-profits. So in short, the line is not a stark one at all. That, I think, points to a broader perspective on this issue. And it's not just about non-competes, but it's about addressing anti-competitive conduct in the health sector. There are very few bright line rules. The best policy doesn't come from good laws. The best policy comes from concerted effort by the agencies. And if the agencies really saw bad conduct, whether it's through non-competes or through hospital mergers, there are lots of ways they could target it. I often get questions, and this is where our conversation really began. How could the FTC or the DOJ have allowed the kind of mergers in the insurance industry and the hospital sector that have taken place over the last 20 years? Aren't these illegal? My answer is they are illegal. They're kind of hard to prove. They require a lot of prosecutorial investments. But yes, a lot of anti-competitive and therefore illegal conduct has happened and is happening in the health sector over the last 40 years. And the real question is not what do the laws allow the agencies to do? The real question is what are the agencies determined to do? And in that sense, I fully embrace Danielle's response to the question, which is, look, the DOJ has different authorities that it could use, and it's encouraging to hear that they're going to use it. One last comment is that to a large degree, the FTC rule that bans non-competes altogether, I think, is a response to this problem of lack of enforcement over the last 20 years. For the most part, any non-competes have been viewed through the lens of antitrust as a rule of reason question, which basically means we measure the benefits compared to the costs. It's a cautious approach. It's a detail-intensive approach, a data-intensive approach. And the FTC, in issuing this blanket ban, is effectively saying, we're tired of measuring things. we're going to come out with a stark rule that's addressing everything. And that, I think, in many ways is a question, is a blanket rule an appropriate response to decades of poor enforcement? Or, I'll put this as an alternative, is Danielle's response the right response to decades of poor enforcement, which is basically, now we're really going to take this seriously and going to harness our enforcement energies? That, I think, is a really important question.
Those are some really great comments, and we're going to come back to precisely that question, the last comment that you had. I wanted to give Stephanie a chance to comment on the nonprofit question, since you have.
And then Stephanie, I would love it if you can also specifically answer if nonprofit is a tax shield as well as a nonprofit is a regulatory shield in many ways for these organizations, large health systems that essentially use that status for everything.
Yeah, and I think we've kind of talked about different components of this, but what we are seeing is an increasing collapsing or consolidation of markets. And so looking at what behaviors are driving that, I think non-competes are one of them. I think some of you mentioned, I think the tax code, the tax favorability that nonprofit hospital systems enjoy allow them to make investments in certain areas that may not be available to other types of entities. So, and I think from our perspective, when you look downstream at consolidation, whether it's vertical or lateral, anything that begins to interfere with that physician-patient relationship and that, interference in the clinical autonomy and challenging what goes into a decision in a patient encounter, I think becomes really important. And so, I think, again, the notice of proposed rulemaking, while you're right, it may not be that we take this big broad swipe at it. I think it started a really important conversation about how these are being enforced in the marketplace and how clinicians especially are moving around or not moving around. In primary care, we are facing a shortage of 48,000 primary care physicians by 2034. And so when you start looking at untenable employment environments, we are seeing more of our members pursuing non-clinical careers. And so I think we have to look at all the behaviors that may be driving that, and non-competes are certainly one of them.
And it's a very interesting point. Even as a specialist, as an orthopedic surgeon, there are 50% of the counties in the United States that don't have an orthopedic surgeon. 50% of the counties in the United States. So as you can imagine, they're concentrated a lot in the big metropolitan areas, but a lot of shortages in rural areas. So if you put a non-compete law there, really kind of changes the dynamic quite a bit. So my question is really, next question is for the lawyers in the room here. So Barak, Danielle, why do non-competes not apply for lawyers? Why should physicians be treated differently and healthcare workers be treated differently? Lawyers as a group have essentially decided that these rules don't apply to them, but they are the ones enforcing them. So I'd love to hear your thoughts on why different skilled workers should be different than other skilled workers.
Yeah, it's a great question. And so as you just noted, the ABA, which is the American Bar Association, which basically releases ethics opinions and most states have adopted their model rules as to how lawyers should conduct their business. They came out with an opinion that essentially said that lawyers should not be subject to non-competes. They really valued the options that lawyers had when they moved to different firms. I think that this highlights, I guess maybe ironically, some of the reasons why, as Professor Richmond was mentioning, sometimes aggregate action is the best one. Regulatory action might be the best way to address a market failure. If we look at maybe the smaller example of the ABA discussing that with respect to lawyers just generally, but even if we look to the bigger question of the FTC essentially banning non-competes with specific exceptions, and the DOJ has, with respect to the FTC's non-compete rule, has acknowledged that sometimes aggregate action is the best way to pursue these cases. I know Professor Richmond just mentioned, the different approaches of going one by one versus specifically with some of the laws that we're up against with the rule of reason and court cases. I think that there's a plug to be made for addressing some of these harms wholesale versus doing it in court one by one.
I mean, I think that's exactly right. And I also think that I think, you might have phrased the question slightly incorrectly. It's not so much that lawyers have decided these rules are not going to apply to them. It's more a matter of that the profession has decided that they will not restrict employment. In many ways, it's a prohibition on restricting employment. And it was a professional decision. It was based on a code of ethics, very similar to what Stephanie said about the commitment between a physician and a patient. Lawyers said that what is paramount is a lawyer-client relationship. And if a lawyer wants or needs to move away from a firm, they still should be entitled. In fact, they're ethically obligated to maintain that lawyer-client relationship. Now, I don't want to go overboard. I don't want to represent the legal profession as a paradigm of the highest ethics in any way. But it does show that when you make a collective decision, an industry-wide decision, then you can solve certain problems that you cannot if you allow effectively freedom of contract. I will also say that lawyers and the legal industry has figured out how to balance against the harm of employment, of free employment. You cannot just take your firm's intellectual property or client list and capitalize on it down the street. And the medical profession could do this. The medical profession could come up with collective rules to encourage recruiting and training and investments, but at the same time allowing more free mobility. In fact, actually, I think it would be a terrific thing for the AMA or other industry leaders in the sector to take on.
Thank you very much. That was really great. So before I ask Stephanie our next question, I wanted to remind our audience that we encourage them to ask questions. We really care about their perspective and encourage them again to just use the Q&A feature to ask questions. So Stephanie, there are as we've commented on many sort of specific aspects of the healthcare sector that on some aspects of this of non-competes and their impact that go beyond healthcare, that apply more broadly, but there are some specific aspects to the healthcare sector that are really interesting. One of these is, and I would love your perspective on the ways in which health systems might use credentialing and privileging as ways to essentially lock physicians into non-competes indirectly through indirect routes. So maybe explain those processes a little bit for the members of our audience who might not be super familiar with them. Thanks.
Sure. The way that it was explained to me was credentialing is asking a chef to show their culinary degree, and privileging is asking them to show you how to julienne a carrot. So a lot of times these we have seen in some of the community hospitals where there may be entities that come and purchase them and flip the business model. And so we had members that were able to provide hospital care. So really that continuity, they're seeing their patients through all care settings, have their privileges terminated by a health system as a point of leverage. And now that may have been very much a part of their practice due to the community needs in their population. And so they use that as a leverage point to say, hey, listen, there's a way around this. You join our network, you're able to continue to see your patients in our hospital system. And by the way, you need to sign this non-compete. And so these things taken together, you really have this captive workforce. And we know that in a negotiation, it's the ability to walk away that is what is leverage. And if you cannot walk away, you can't negotiate pay. I mean, there are multiple things. And so these are ways that independent practices are really facing challenging times. And so that's why the number of people that are in an employed setting are increasing. And so the privileging and credentialing process is one way that systems are using to drive independent practices into their systems.
Stephanie, just to build on that, can you also talk about this whole value-based field? So, the value-based care is kind of the big buzzword for CMS. It's the big buzzword for everybody. And the idea is to improve outcomes, reduce costs, and then do it in a synchronized manner where physicians and health systems are working together. But do you feel like value-based care can sometimes be used to essentially affect physician practices or physician behavior, where the fund flow may not necessarily match and go downstream to the physicians, and then how
Yeah, so I think in our, from our perspective, I think it's very important who is defining value. I mean, I think primary care, the value is in wellness and prevention and effectively managing patients in the appropriate site of care. And so, a lot of times when primary care practices are in these larger systems, those tenants are at odds, they're in competition. And so, as we see a lot of these payment models coming to the forefront where they're recognizing, hey, if we resource primary care better to manage their population on the front end, we are probably going to see better outcomes. And so we're starting to see a lot of that. The challenge becomes when they are engaging in those arrangements at the entity level, you may see practices where the physicians are still contracted on a productivity basis. So they're still kind of in that do more, in utilization. And we know with utilization, that doesn't always amount to the good outcome. So if we're talking, goals just need to be aligned. And I think there are plenty of systems out there that are doing that. But I think making it very clear that the goals of a system and the goals of the practice can very often be in competition with one another. I think that's a very important conversation to have, because until we are resourcing, and again, I can only speak for primary care, until we are resourcing primary care to more effectively take care of a population, I think we will continue to be on this hamster wheel.
Thanks very much. So we have another question from a member of the audience, which I think I'm gonna ask Danielle perhaps to comment, and of course other panelists should feel free to jump in. So the question is not an easy one. So if non-competes by definition can only be properly used to restrict competition and not to handcuff key employees into service, then the question is, how is competition in healthcare being defined? So is the solo doctor practice really competing with the mega hospital system? Where is the distinction being drawn by regulators or otherwise? As an economist, I know that this is it's not an easy question, but it's a very consequential one. Like the way in which you define the market can really change the outcome of of a certain practice and so on. So Danielle, what's your perspective on this?
Yeah, no, that's a great question. As Mario, as you highlighted, market definition is often paramount in some of the ways that antitrust cases get resolved. So I guess maybe taking a step back, when we're thinking about non-compete clauses, I think there are two issues related that touch on we can call it market definition, but maybe just as the questioner phrased it, what is a competitor with respect to an employee in a non-compete clause. I've actually seen non-compete clauses. The fun part about being interested in this topic is that a lot of my friends actually showed me their non-compete clauses. And I have seen some non-compete clauses that are extremely narrow within the four corners of the contract. So, they define competitor as like a very, very small subsection of potentially what this person could do. But then, some contracts leave them. You just can't work for a competing employer, and you certainly can't strike out on your own. So just wanted to put that sometimes these are defined in the contracts, and that can also kind of play into some of the market definition. As far as market definition areas, market definition hospitals and the healthcare system generally, that's a very economists have employed many tools to try to get at the correct market definition. In the antitrust world, we generally look for harm in any market. So we want to make sure that we're not defining markets too broadly or too narrowly to capture the actual relevant competition. As you had noted, I think in your question, solo practices might not compete with the mega hospitals that can offer lots of different various types of care. So this is all taken into account when we look to defining the market for competition and the relevant market where we're assessing that competition. With respect to non-competes, courts have gone through the market definition exercise much like they do in a typical merger case. And as I mentioned, there are lots of different complex tools to get there. The one area where the Department of Justice has weighed in recently on non-competes involved the market for anesthesiologist services. So we weighed in with a statement of interest, actually in a Nevada court case involving a non-compete clause. There were anesthesiologists that were subject to pretty egregious non-compete clauses that would essentially tie up 2/3 of the state of Nevada and would prohibit them from moving from practice to practice. So there, we didn't specifically comment on the definition, the market definition there, but just to give you a sense of how courts sometimes look at it, the market was anesthesiologist services. So it can also be defined on the types of service, how large or how small the practice is, and then also if they're just geographically, right? So if they're offering their services to folks in rural areas versus a city hospital, those can often look a lot different and compete differently. And I think, antitrust law, especially now as we're looking towards more of the realities of competition, we want to make sure that we're looking at actual competition as it occurs, not just maybe how an economic model would say that it's happening.
No, that's great. My question, I guess, building off that is for Barak. Barak, where should the regulatory burden lie? Should it be at the state level, at the federal level? And whose job is it to really secure patient access and advocate for patients? Because one of the areas we haven't really talked about is the huge impact that this has on patients. So if a doctor leaves the system and can't operate or set up a practice in the same area because they have to essentially leave a 20-mile radius or 10-mile radius for 2 years or whatever the negotiated terms were, that really impacts patient access and impacts patients' care. And whose job is it to advocate for the patient? Is it the state level? Is it the federal level? Is it somebody else? And love your thoughts on that.
So, as a functional matter, I think anybody, any policymaker has certain authorities within their jurisdiction to improve the healthcare sector writ large, in particular as it relates to the competition of the labor markets. Now, that's the general answer. I don't know if it's everybody's job, but certainly everybody can. Now, non-compete law is mostly based on state law. So this certainly does carve out an opportunity for state actors, whether it's the legislatures or the attorneys general, to modify the underlying law. Actually, also within the judiciary, also the state Supreme Courts can change the law, and state enforcement officers, in particular state attorneys general, can police it, can make sure that all non-compete clauses, to the degree that there are any, are comply with whatever rules the states have. One thing that's really important, and I think it was Mario who brought this up early on, or maybe it was you, Amit, states are not of one voice on this. The law of non-competes does vary state by state. And in that sense, not only do we have a laboratory of democracy, as Justice Brandeis once put it, we can actually figure out what rules really do work best, but it's also a market opportunity for certain states to advance better healthcare systems and to attract physicians. There was a very famous study of looking at non-compete clauses for engineers, contrasting the approach in Silicon Valley in California under California law and Route 128 in Massachusetts. And there are a lot of differences between those places, not the least of which is the weather. But one difference really is the enforcement of non-competes. California did not enforce and does not enforce non-competes among engineers. And a lot of people have attributed the rise of Silicon Valley, in contrast to Route 128, starting in the 80s, going all the way through the current day, as crediting a different approach to non-competes. So states can do a lot of things. Having said that, it is not only a matter of state law. Federal policymakers can approach not just non-compete clauses. The Federal Trade Commission can, within its authority, issue certain rules. The Department of Justice can enforce the Sherman Act, because even if something might be legal under state law, it might not be legal under federal law, and it might be a violation of the Sherman Act. But, I will also say that just scratches the surface of what both federal and state policymakers can do, not just regarding non-compete clauses, but regarding the efficacy, the quality, the value of competition in the healthcare sector. There are a lot of mechanisms that are available to make healthcare markets more competitive, to make the labor markets more efficient, to give enormous opportunities to individual physicians. And that includes the use of telemedicine, the use of licensure law, certainly reimbursement law, the ability to start new practices and new hospitals. There are certain bans to the development of new physician-owned hospitals. There are lots of entry barriers. We also have certificates of need. We also have certificates of public advantage, which are ways of getting around the antitrust laws. There are lots of ways that we can improve the healthcare sector. They involve actions by both state and federal policymakers. And again, I think a lot of it really does involve the political will. How much of a priority is it to address the dysfunctions of the healthcare sector? And how much of a priority is it to enable physicians to tend for their patients? And how much of a priority is it to make sure that patients have access to a competitive marketplace?
And I think I would add to that, I think there is 6 states that currently ban them for physicians. I believe that's correct. However, we have heard from physicians in some of those states that they have seen non-compete clauses in their contracts. So when you ask whose job it is to oversee this, I think there's, we take a responsibility in making sure our members are looking over those contracts, that they're aware of what is going on, and they can say this is illegal, because they are assuming, I believe, that by virtue of including it, the employee is going to believe that that is enforceable. And so making sure that they are educated going into those contracts is very, very important.
Thank you. So I love the way in which the audience is asking questions and responding to participating really in the conversation, because Barak earlier mentioned enforcement and variation. So this question, I think it's for Danielle. What is the historical success rate of challenging non-competes? And are there any sort of features of the employment relationship besides, certain states, don't enforce, other states do? But what do we know about what determines whether a non-compete is successful, challenged successfully or not?
Yeah, that's a great question. I think that FTC's rule actually does a good job of going through the history of challenges to non-competes, and I think lays perhaps a good foundation for why greater action, as we've discussed, is needed here. So under the antitrust laws, I think Professor Richmond had alluded to this earlier, there's kind of 2 types of analysis per se illegal, which means that if you get to court, subject to certain exceptions, it will generally be deemed illegal. And then rule of reason, where the court engages in like a balancing analysis. Typically, once courts get to the balancing stage and they're asked to evaluate a non-compete, those challenges are wholly, I would say, for the most part, unsuccessful. There have definitely been some cases where non-competes are extremely egregious, either via geography or in the time sense. But again, I think that this highlights why certain regulations, or at the state level, as we've just discussed, or even at the national level, may be needed to remedy some of these market failures.
So my question is for everybody, really. We all have been talking a lot today about non-competes as a way to, or getting rid of non-competes as a way to promote competition. So my question is competition really good for healthcare? So in other words, does competition actually result in lower cost, improved quality of care delivered, improved patient experience? And is that something we should strive for? And there are a lot of things that Barak mentioned: certificate of need laws, physician-owned hospitals, etc. All these things that in some ways affect competition. So my basic premise is competition actually good for healthcare? Does it actually improve things? I'd love each of your take on it.
I just quickly add that Can I just quickly add that this is a great question that we could do a whole webinar on this one. I'm speaking as an economist, but I'm really, really curious, as Amit is, to hear our panelists' perspective on this.
The answer is an unequivocal yes. It is better. You have lower prices, you have higher quality, you have better job satisfaction, you have for physicians, you have better patient experiences. The answer is yes, yes, yes. The reason the question is interesting is that why is it that it's still a question? Because it is true, whether it's courts adjusting mergers, whether it's legislators imposing certificates of need, whether it's different maneuvers to restrain competition, the purported justification over and over again is that some kind of free market competition is bad for patients and bad for the sector. I think the bigger question is, why do we still have that narrative? Why? Because it's not supported by the evidence, very much the contrary. I think that there's some good answers for that. To a large degree, we still we trust industry inspired and industry interested data and metrics. We also have we do not have a political economy where those who benefit from competition are on equal footing with those who benefit from lack of competition, monopoly rents. But it's very much worth interrogating not the data, but the persistence of the myth.
Stephanie, your take on it?
I would agree. I mean, competition is good for everyone. It's good for patients. It's good. People that are happy in their employment environment are better at their jobs. I don't care what the industry is. And I think, when you think about pricing, when you think about, negotiating with one player or negotiating with several, I think that's where the challenge is, that increasingly you have these large systems and in a sense, they can name their cost or their price. So, I think having a little bit, having competition is inherently good for the market and for patients.
Danielle?
I suppose you could probably predict my my answer, but I certainly think that robust competition can cure a multitude of ills, and I think we've seen it time and time again in the healthcare space. I know we have briefly touched on some of the areas involving mergers in the healthcare space, and some frustration about the potential lack of involvement from the antitrust authorities in stopping those mergers. I will say that we had released some merger guidelines recently and opened those up for comment. And well, first, the most I guess prolific industries to comment were the writers that were on strike. I think they had nothing to do, so they were just writing into the agencies about their merger guidelines, and they were very beautiful pieces of work. But the second area that we heard from most often was in the healthcare industry. And I think all of these issues we've talked about with respect to non-competes and the lack of competition also were reflected in those comments with respect to mergers. People who had lost their jobs due to a lack of healthcare competition, who had had lower wages or just worse care. And I think often maybe my comments have focused more on wages for workers, but I think that the comments there did a great job of tying it to patient quality of care. There were lots of stories about how they just could not adequately care for their patients based on solely the lack of competition in the healthcare space. So I definitely would put in a large plug for competition in the healthcare space. And I'm so glad that you guys are thinking about this and having these types of discussions, because I really do think it's imperative for the next years in the healthcare world.
Thank you. The next question is from the audience, specifically for Stephanie. So what should state medical societies do regarding non-competes? And this person says, our membership is split 80-20. Stephanie.
I suspect that your membership is probably split based on their size. And as I said, I do think there are times when smaller practices have different considerations about how they make those front-end investments in recruiting and attracting employees to come work there, and the disruption it causes after they've financed onboarding them and helping them build a patient panel to help, to have them go elsewhere. that's not what I'm focused on. And we do hear that, and we actually believe that there are considerations for those smaller practices. So I would say, in terms of, how we're approaching it, it's kind of keeping our eye on the prize of these behaviors and other business interests that it may be contributing to. Very rarely are these things happening in isolation to other anti-competitive behaviors. And so I think just keeping that top of mind, and also really that ongoing dialogue. I mean, we have state chapters across the country where we're engaging with them to understand what their legislative landscape is looking like. And, a lot of the ones that have concentrated health systems are not faring as well on this front from the physician perspective. But I do think it's an important conversation, and I don't know that we would be able to effectively design a singular policy that meets everyone's needs. So it does need more consideration.
Could I just add to that? I think the question is an outstanding question. I think Stephanie's presence here, let's put it this way. For much of American history, the medical profession, physicians, did not want enforcement of the antitrust laws to the health sector. The fact that Stephanie is with us on this panel today is a hallmark, is a it's a great accomplishment that people like Danielle and the antitrust industry have actually been able to convince physicians that competition is good for them. Now, to some degree, it might be too late. It might be because all of a sudden the poor enforcement of the antitrust laws enabled the rise of giant hospitals, and now physicians realize, maybe too late. And Stephanie, this is said with a lot of affection and admiration. Lo and behold, actually, physicians might be the victims of anti-competitive conduct, not just the beneficiaries of it. I think that it is a really important development that physicians now realize that anti-competitive conduct does harm not just them, but also the patient experience and outcomes. And I actually would encourage medical societies to be much more on the offensive, to really try to inject improvements into the healthcare sector. I recognize that they represent a heterogeneous constituency, and I recognize that's hard. But just like the vast majority of physicians thought that antitrust laws were a bad thing 20 years ago, and now it might be more mixed. I would suggest that if we continue with the status quo, 20 years from now, all the physicians will finally realize that it's a good thing. And again, it might be even more too late. So I encourage a lot of leadership, not just on the antitrust laws, but also we need medical societies to recognize the harm from certain licensure restrictions, restrictions on telemedicine, restrictions on interstate competition. There still remain a lot of traditionalists, let's say, a lot of those among the medical profession in positions of leadership that are resistant to competition. And I'm very hopeful that Stephanie is a hallmark of what's to come. And I hope that people like her assume greater positions of leadership, and we all need them to.
Oh, thank you. And it's been really an outstanding conversation. I know we're coming up on the hour. I just want to very quickly, I know there are some audience members who are FTC and other employees who are listening in, and right now FTC is in an open session where they're seeking comments. So from each of you, very quickly, just one line on what's your personal opinion on what the FTC should do. So start with Barack, since you were just up. What should the FTC do? It's one line.
Very succinctly, I think the FTC should really focus on the harm of hospital-led local monopolies. That's the real problem. That is a much more important imposition on physician labor and physician freedom and physician quality than non-competes.
Stephanie?
Yeah, I think using its existing authority, looking at the acquisition of physician practices and the use of non-competes. My wish list is obviously to extend that to nonprofits as well, but I understand the challenge.
Danielle?
Yeah, I think the FTC's rule on non-competes was really well done, and the division has come out in support of that. So I would just encourage them to keep going. I know they have a lot of comments to review, and just look forward, like all of us, to that final rule to determine what the fate of non-competes is nationally.
Well, thank you so much to all three of you for an outstanding panel and a great conversation. I'll give Mario the closing word.
Oh, thank you. It was a really outstanding conversation. Thank you so much.
Okay, and thank you to the audience for your participation and hope everyone has a wonderful day. Take care.